Hello, my name is Dr. Kumkum Patel. I'm a board certified gastroenterologist, and today we're going to be talking about constipation. Or is it more like coordination of your rectal muscles, that is? Let's talk about constipation based on what your stool looks like. And I want you to use foods because I feel that that's the easiest way to talk about your stool is using things like, does it look like milk duds? That could be a sign that you actually have constipation. Type 1 is hard lumps that are like milk duds that are hard to pass. Type 2 is when those milk duds have started to actually congeal, but it's still hard for it to come out. Type 3 and 4, now that's what you're actually trying to go for, okay? So this is what we call normal bowel movements, where there's congealed pieces of stool and they've congealed together with some cracks on the surface. Type 4 more looks like a perfect Snickers bar that has it got ends to it that are very defined, and it comes out nice and smooth and soft. Type 5 has gotten to be too soft, where it's basically like melted Hershey kisses, if you would. It's got soft blobs, clear-cut edges, but it's coming out not too hard. And type 6, it's turned into fluffy chocolate oatmeal, and type 7, it's turned into water, entirely liquid. So now if you don't ever want to eat chocolate ever again, I don't blame you, but use these foods to describe your stool to your gastroenterologist. So how is constipation really defined? Not obviously just by those that chart, but also if you have 2 or more of the following: straining during a quarter of the bowel movements, lumpy or hard stools more than 25% of the time, a feeling that you're still not completely empty even though you've gone to the bathroom, a sense of obstruction, or needing to use your fingers or move from side to side or support your vagina in order to have a bowel movement, having less than 3 bowel movements per week, and having loose stools rarely present without the use of laxatives. So if it's not one of those, it might be a problem with something of the coordination of your rectal muscles called dyssynergic defecation. And how do you know if you have that? Well, if you're having excessive straining, having a feeling of incomplete evacuation, having a passage of hard stools, having less than 3 bowel movements a week, and specifically, if you're using digital maneuvers, which means you're using your fingers to help with the passage of the poop itself. Some people say, you know what, I've had constipation lifelong, and I've had it since I was a kid. Well, that might be actually just what we call slow transit constipation, where you've had it for a long time, you're laxative dependent, and you've had it since your childhood. But if you have things such as backache, a history of anorectal surgery, sexual trauma, birth trauma, that could be a sign that this may be something called pelvic floor dysfunction. And remember, all of these can actually overlap. So it's not that you have just one type of constipation. They may be more than one thing that be contributing to it. So if you have abdominal pain with all of this, you may even have IBS type C. So again, it could be a problem with the coordination, it could be slow transit, or it could be IBS type C. So what is dyssynergic defecation? Why do I want to talk about coordination? Well, it's an acquired behavioral problem due to the inability to coordinate the abdominal and the pelvic floor muscles to allow your poop to come out. Dyssynergic defecation is seen in up to 59% of patients, and slow transit is almost seen in approximately a half. And remember, like we said before, there's a large overlap of people who have dyssynergic defecation, which is the muscles, slow transit constipation, which means it's just moving slowly, and IBS type C, where there's pain associated with this. And obviously, these lead to high utilization of healthcare costs with emergency room visits, lab tests, outpatient services, up to $7,500 per year. One thing to recognize is that your symptoms may not just be on their own. They may be associated with psychological distress. If you have depression, anxiety, OCD, somatization, they could also be exacerbating your symptoms. So if you have that, it may lead to IBS-C, which could make the other types of constipation worse. So how exactly does dyssynergic defecation happen? Well, it's one of 3 big things. It's either that you don't have enough pressure in your rectum to push the poop out. That's called inadequate propulsive force. Or you have something called paradoxical anal contraction, which means that the actual muscles themselves that you can control in your rectum are actually squeezing when they should be relaxing instead. Or you have inadequate anal relaxation, which is actually preventing the poop from coming out. Some people even have something called impaired rectal sensation. And this means that they're not even able to feel that they have poop in their rectum so badly because there's so much poop. That might be a sign that you may have impaired rectal sensation. Again, studies have shown that people who have these abnormal balloon expulsion times, and we'll talk about that, have one of these three things: high sphincter pressure, inability to push the poop out, or a combination of the two. So how can we diagnose you with dyssynergic defecation? Well, the first step is to make sure you don't have some other type of thing contributing to your constipation. Maybe it's your thyroid, maybe it's your diabetes, but we want to make sure nothing else is going on. So usually a colonoscopy or a flexible sigmoidoscopy can be used to rule out solitary rectal ulcers, cancers, or anything else that could be causing a blockage or inflammation. Then, when you see your gastroenterologist, you're going to have something called a digital rectal exam. Your gastroenterologist will use their finger to feel for the following. They're going to ask to see if they feel stool. And if they feel it, they're going to see if you can feel it. If you're unable to feel that there is stool in your rectal vault, that might be a clue that you have impaired rectal sensation. They're going to see if there's any strictures, narrowings, or something that's actually causing your rectum to have spasms. Your doctor will ask you to squeeze to see if you're squeezing too tightly, and they're all going to ask you to push down to see if you're able to push the finger out. This is to check the strength of your muscles before they do any further testing. They should be able to feel for abdominal pressure because remember, you use your abdominal muscles as strength to push poop out in addition to coordinating your rectal muscles to relax while the poop comes out itself. Dyssynergic defecation happens when these above findings are abnormal. So the next thing you're going to get, besides a digital rectal exam, is something called an anorectal manometry. This is where we use a probe to insert into the rectum. You're asleep on your side, or actually you're not asleep, you're on your side, and you're awake for the procedure. You don't need anesthesia medications. And we ask you to rest for approximately 5 minutes. Then we ask you to squeeze approximately 3 times. And then we ask you to bear down and attempt to defecate. During these maneuvers, we check to see what the pressure is in your rectum, as well as what is generated by the anal sphincters. And based on what happens throughout these studies, we can see, is it too much pressure? Is it not enough pressure? Or is it just staying the same? And there's 4 big things here that we can look for. The patient can generate adequate pushing force, as in you're using your abdominal muscles properly to push poop out, but there might be a paradoxical increase in the sphincter pressure, as in you're squeezing your external sphincter muscles on your own when they should be relaxing. The other ones is that you may not have adequate pushing force, and in addition, there might be inappropriate contraction of your rectal muscles when they should be relaxing. The next thing we could be doing is something called a balloon expulsion test. This is when we use a 4-centimeter small balloon with about 50 milliliters of water, and we place it in the rectum. We ask you to sit on the toilet, and we give you a stopwatch. And we ask you to push the balloon out as if you're pooping. It should take you no more than 1 minute of time to push it out. This is to simulate what it should feel like when you've got poop in your rectal vault. It should not take you more than a minute to let it out. So when your husband tells you that he's been in the bathroom trying to poop for 30-something minutes, that's not normal. That's actually abnormal. Get them a balloon expulsion test or tell them to stop reading. The next thing you could do, you may have an anatomical dysfunction that might be leading to something called dyssynergic defecation. This might be something called a rectocele. As you can see below, you have a little pouch that can actually hold on to poop for a long period of time. And that in itself can make you feel as though there's something left behind and you're not fully empty when you have a bowel movement. We can get something called an X-ray defecography, which is found here at St. Jude, or an MR defecography. 150 cc's of barium paste is placed in the rectum, and then we take a picture to see if some type of anatomical abnormality comes out. If it does, we could refer you to one of our specialists at our center to have this repaired. And the last thing is that if all of this is normal, then you might have something called slow transit constipation. We can check your colonic transit time, which means we'll see how long it takes for the poop to come out. We use something called a SITS marker study, where we ask you to swallow the markers, and then we take x-rays at day 1 and day 5. If you have more than 20% of the original markers still sitting in your colon at the 5th day mark, then you likely have something called slow transit constipation. And sometimes we can put you on medications to help with this, okay? Retention of most of the markers on the left side of the x-ray can show that there might be a pelvic floor dysfunction. So how can we help you get this treated? Well, biofeedback and pelvic floor physical therapy. It's the mainstay treatment of dyssynergic defecation. And of course, at St. Jude Pelvic Health Center, these are available. So what is biofeedback therapy? Well, the aim is to help teach the patient how to coordinate those abdominal and pelvic floor muscles to help them during having a bowel movement. During biofeedback therapy, they're going to help assess the rectal sensation, how you're able to push out that rectal balloon, and they'll teach abdominal breathing exercises and adequate ways to generate enough force to push the poop out. They'll teach relaxation techniques so you can relax your anal sphincter and kind of coordinate this with the rectal pressure. And of course, the goal is to try to shorten that rectal expulsion time. Remember that 1 minute time that I talked about? That's the one they're trying to get you to. You need at least 4 to 6 sessions, maybe more, at least a few weeks apart, to see some benefits. But that's not all. Sometimes, like we said, your constipation may have more than one cause, and you may need medications to treat something like IBS or chronic constipation. There's medications like lubiprostone, which can be taken once or twice daily. There's linaclotide, which is Linzess, which can be taken for IBS-C and chronic constipation. And there's also Trulance, which helps again with pain, bloating, and constipation. So in summary, if you haven't paid attention to a single word I've said in this entire time, I do want you to be able to take the following away. If you think you may have dyssynergic defecation, as in you've tried conservative management, you've tried all the Miralax and fiber and over-the-counter therapies on your own, and you're still not having a good bowel movement, and you may have some abnormal history such as trauma, birth trauma, sexual trauma, pelvic floor surgery, consider talking to your doctor because you may need testing through anorectal manometry or a balloon expulsion test. And remember, if this is abnormal, you will likely have something called pelvic outlet dysfunction or pelvic floor dyssynergia. You'll get treated with something called feedback and pelvic floor physical therapy. If that doesn't work, we'll check to see if you also have anatomical dysfunction with something called an X-ray or an MR defecography, where we see if you have any defects from, let's say, childbirth. If all of these things fail, we can always check to see how slowly your colon is moving and consider either repeating your feedback therapy or even referring you to a surgeon. Some of the common questions that I get asked about dyssynergic defecation or constipation in general is, how much fiber should I be eating? That's a great question. If you're eating fiber, that's the first step. But how much? That's also a good question. The American Dietary Association recommends at least 25 grams of fiber for women and up to 38 grams of fiber for men. So what types of fiber? You're probably getting confused. There's soluble fiber and insoluble fiber. Soluble fiber is found in things like fruits or chia seeds, and they help form a gel so that you get full faster and helps move things along. Insoluble fiber is found in things like cruciferous vegetables like broccoli, Brussels sprouts, and kale, or in bran flakes. So eat that if you're looking to have faster transit, as in you want your colon to move faster. A combination of both is recommended so that you can get your daily fiber intake. Another question that I get asked is a colonoscopy needed in an evaluation for constipation? The answer is Yes. If regular therapies are not working for you to help with your bowel movements and you're still struggling, there may be more than one reason. And the one we want to rule out that's the most important is colon cancer. That's one of the leading causes of death, and it's preventable. So we want to make sure that there's no anatomical abnormalities, and specifically, we want to rule out colon cancer. And last but not least, what can happen if the pelvic floor physical therapy is not helping? Well, we can do a couple of things. We can reassess why the therapy didn't work. We can also reassess to see if some things such as cognitive therapy or seeing a psychiatrist may be helpful, as a lot of anxiety, depression symptoms may be associated with your constipation and can be worsening it. Being on medications for those can actually help it, because serotonin, which is your happy hormone, can actually also modulate how your bowels move. So don't be afraid to seek help for both of them. And remember, your gut and your brain are very intimately connected. And so we're happy that you're here, and we're here to help.